catheter and inflated to an appropriate pressure to eliminate any areas of narrowing, stenosis. Multiple balloon inflations may be required to successfully eliminate any areas of abnormality and improve the flow through the vein in question. After successful performance of the balloon dilatation, final images of the jugular vein or the azygous veins are performed, and then your operating physician will discuss the findings and results with you before leaving the room. The staff will then transport you back to the recovery room for sheath removal and brief convalescence. Once in the recovery room, one of our nurses will remove the intravenous access sheath from the femoral vein and hold pressure at the groin site for 10 or 20 minutes. The upper thigh site of venous access is carefully cleaned and prepared with a simple bio-occlusive dressing, which is left in place following the procedure. Finally, we often place a sandbag on the thigh and groin level to decrease the likelihood of any significant bruising while you await loved ones to return to the recovery room.
So we really have to thank those patients who agreed to take part in those videos for us. Those were actual patients, and I would say there were a couple of clips that I would have changed had I had the opportunity. You know, I mean, you can see the IV is not terribly comfortable when the IV is started, but I think it gives you an idea of kind of how low level the invasiveness of this whole procedure is, and hopefully takes away a little bit of the anxiety that goes with it. And you know, I think that's important for patients to realize. So we have some microphones set up. I mean, it's a small enough room so that if
One,
you just
two,
talk
three.
loudly, you probably don't need to use the mic, but if you want to, we can hand it to you, and I'm happy
If
to answer
anyone
any
wants me to
questions.
hand them a microphone, just raise your hands and I'll bring it to you so you don't have to get up. Any questions?
Do you have the equipment for the Hakey protocol at Rhode Island Vascular Institute?
Yeah, it's a funny thing. I mean, most people who have a 3 Tesla magnet, Rhode Island Vascular Institute is actually one office of a larger radiology group. We have 7 offices, and we provide radiology services for 3 hospitals. So we have 2 3 Tesla magnets capable of doing the protocol. It's a matter of writing the protocol to have the machine do what you tell it to do. Most people who have a 3 Tesla magnet can achieve actually 1.5 Tesla, which is not even as powerful.
That was the first part of a 2-part question. And the second question is, the only place the Hakey protocol is done at present is in California at one clinic there.
Right.
Is there a possibility that it can be offered for a given price at your institute as well? Thank you.
It's a tough question, Steve. I would say anything's possible. I can almost guarantee you that as I said earlier during the talk, I think MRV, particularly when the Hakey protocol is used, is an excellent tool. But I think that the current status of third-party payers in the United States makes it so that insurers won't pay for it. And I think that the amount that I've had patients request whether they could pay out of pocket. And what I've told them is we could perform the procedure we could get the protocol and do the Heike protocol that's being used in the Hubbard registry. We'd be happy to do that, but it's going to cost this amount of money. And the fact of the matter is, I have the option here of doing an ultrasound for you, which I think will give me nearly as much information. Now, Hubbard would disagree with this, I mean, and so would Heike. I think that they rightfully feel that their protocol does give additional facts, and it does. But I'm not sure that the additional facts warrant the additional expense that patients in the United States, anyway, would end up needing to pay. I don't know how else I can answer that. I mean, I think that if it was an ideal world, probably everybody would get some form of cross-sectional imaging, and MRV would be a wonderful thing for everyone to get. I just don't know how it would ever get paid for. It's very expensive.
Protocols, MRD, MRI.
Correct.
I have done in Detroit, but not for yourself.
Mhm.
The cost, you want to cover it on the overall, is about $2,500.
Right.
And I think every single patient that has this procedure done, my own opinion,
Mhm.
should have that HAPE protocol.
Yep. You know, I.
Blood flow, the 3D view of the veins.
Right.
I think it's absolutely wonderful. If you have something that your institute could offer, the patient can pay out of pocket or whatever, I think that would be a phenomenal thing to do.
Yep, and you know, and I think that's a reasonable. I do think that it's a reasonable notion. The concept that providing MRVs for all patients to confirm that they do or don't require therapy. You know, I don't disagree with the idea. I just think that what we've done, and we've had the opportunity to ask patients to pay out of pocket and do the protocol. What we've done is to suggest to them that we feel we're likely to get the information we need without the MRV. It's a tough question. I mean, as you can imagine, and when patients are paying out of pocket, we try very hard to do what we can to not have this be unreasonable. So.
The reason I asked the question is because I knew it was
Yep. Yeah.
Well, we can always count on you for those tough questions, Steve, right? Does anyone else have a question?
Sure.
There's a microphone right at the front, or if anyone would like me to hand it to them, I'm happy to come over.
Thank you very much for coming. I really appreciate it. I'm going to go to your clinic, at least I hope to. I had a Doppler done here by Dr. McDonald.
Mhm.
Is that what I need to
Yep.
bring to your clinic?
Yep.
And you guys don't perform another
We
one?
don't.
Yes, you
You know,
do.
we have some of the places that send us ultrasound, because what Sandy McDonald will send us is a diagrammatic representation of your study and a report from what he found, not the actual images. What we found from his clinic in having the earlier patients who we had actual images sent was that we only needed his diagrams. They're trustworthy. There's no reason for us to. There are patients who have, so I'm only saying this not to specifically answer your question, but to answer it for a bigger population. Yes, your ultrasound is done and that's adequate. You don't need to have another one, and we won't repeat it. It is a little bit of an individual thing, though, because if an ultrasound comes from another site that we either haven't seen their images or don't know that we can trust their definition of the Zamboni criteria, we may need to repeat those ultrasounds.
Okay, and if I may, I just want to ask another question.
Sure.
You were talking about the various grades.
Yeah.
Grade 1, 2, 3, and 4, I think
Yeah.
you said.
Yep.
Have you guys seen any similarity to, like, for example, if anyone was grade 1 and their symptoms?
Their level of symptoms.
Yeah.
It's a great question. The question is whether or not the grade of venographic abnormality relates to the level of symptoms. And what we have found is that the big answer to your question is no, it does not seem to correspond. Their patients can have very mild different changes in their venographic finding and still have pretty significant responses or pretty significant symptoms to begin with. But I will say this, what we have found is that patients who are very debilitated, so very far along primary or secondary progressive patients, they tend to have very, very abnormal veins when their veins are abnormal. To the extent that their veins are very atretic, very small. And I think that probably a part of this process is veins are like any other part of the body. After eventually, when not enough flow is reaching that area, remember that picture I showed you, they're draining the nervous system, but they're also draining the muscles of the face, the muscles of the neck. Eventually, when they're getting enough decreased blood flow, they are going to change. So we're talking about very debilitated patients who have limited mobility of their upper body, upper neck, and head. That may be why their veins are so abnormal, but that is one correlation that we found. We found that patients who are very far along in either secondary or primary progressive MS, they do tend to have very, very abnormal veins venographically. As a corollary to that, I'll tell you, what we tell patients is that if we feel the veins are too abnormal, you know, TOO abnormal, for us to be able to treat them safely without really expecting that we're going to need to use a stent, we probably will tell them at that point in time, the venogram shows that your veins are, and I have had patients who have had one vein that was just so abnormal that I felt that there was no likelihood that I was going to be able to repair that vein without putting a stent into it. And we're really trying that hard to avoid stents that I would rather not treat that vein at this time and treat the other vein that I can treat without a stent.
Thank you very much.
Yeah, thank you.
I have a question over here.
This young lady was just about to ask a question before that woman did, so I'll just get one out of the way and then we'll move to the back. If you shout, you don't have to use the microphone.
Yeah, I'll shout. I have a lot.
Okay.
Basically, I guess so my question, I soaked up so much, right? Now, obviously, I'm on medication. Avonex, I'm sure people know what it is. So,
Yep.
but I mean, if I were to do this, does that mean that, because my medication prevents me from
Relapsing.
yeah, flare-ups or, you know, and prevents further damage every time I have, you know, an attack. Does that mean that if I get this done, that do I stop on medication?
The short answer is no. We try, you know, that diagram that I showed you with all the circles going around and showing eventually you get back to the point where there's an autoimmune response. You know, if you buy that theory, and I do, then there's more than just venous abnormalities going on here. And there is a point at which an autoimmune response has been elicited, and that autoimmune response and some of the things that go along with it is still going to respond the way we've expected it to respond in the past with the drugs that people have been put on. So having said that, we don't ask patients to come off of their medications, and as a matter of fact, there is one medication, low-dose naltrexone, that's a symptomatic drug some people have taken. We ask patients not to take that because that does have an effect on the way your body responds to pain medications. It binds to the receptors that your body uses for pain medication. So we ask patients not to be on that drug because it's going to affect how much medicine we need to use during the procedure. We learned that with one of our early patients who we ended up needing to use a huge amount of medication to make her comfortable because she was on LDN. All the other drugs we don't ask, the anti-MS drugs, not anti-symptom drugs, but anti-MS drugs, we don't ask patients to come off them. And, you know, I do have patients who decide not to continue on their medications for one reason or another. They're having terrible side effects. They don't want to have the fevers and chills that go with their interferon, whatever. I still recommend that they continue, and I think, you know, I try to make that point very clear to patients and their neurologists because this is not a us versus them approach. I mean, what we're saying is that we think this has some ability to help patients. We're not asking them to stop the other things that could also have an ability to help them. So I wouldn't ask people to come off their medications. Okay.
You mentioned earlier in your presentation that when you're in the supine position or lying down, people use their internal jugular veins, yet when they're sitting up, they use something that started with R?
No, vertebral veins.
Okay.
Yeah.
So